Hello, my name is Dylan Hoffman. I'm a first year doctoral student in the Indiana State DAT program, class of 2021. And this presentation is over a comparison of lateral ankle sprains and MCL sprains and the clinical decision making associated with that. To start this conversation off, I want to look at a review of the anatomy. Looking at the ankle, the static stabilizers of the lateral aspect of the ankle and the talocrural ligament or talocrural joint are going to be the anterior talofibular ligament, the calcaneofibular ligament, and the posterior talofibular ligament. Of these three, the most commonly injured is by far the ATFL, and that is because it has the lowest maximal load compared to the other two ligaments. The next commonly injured is the CFL, but rarely is that ever going to be affected in a grade 1 ankle sprain, lateral ankle sprain, because the ATFL was not stretched to the point that it became compromised. So likely you're going to see isolation injuries to the ATFL when the mechanism is inversion coupled potentially with plantar flexion. Comparing that to the anatomy of the knee, the medial aspect of the knee has the MCL as its main stabilizing force. Your MCL can be separated into deep and superficial aspects. The deep MCL is made up of the meniscofemoral ligament and the meniscotibial ligament, with a superficial MCL running over that. Of these, the one with the lowest maximal load is the deep MCL meniscofemoral ligament, particularly where the deep MCL attaches to the femur. Moving from that, I wanted to discuss some of the comparisons and things that are in common with both injuries. Both do really well with early rehabilitation. Evidence has shown early rehabilitation to be extremely effective in treating both lateral ankle sprains and MCL sprains. What's also been shown in the evidence is immobilization negatively affects recovery. That has kind of been well understood as far as lateral ankle sprains, and I think early rehabilitation of those has been relatively and regularly practiced, but grade 1, grade 2 MCL sprains may still be treating with some immobilization or limited range of motion, which has been shown to negatively affect some of the outcomes in recovery. In addition to this, surgical intervention is not necessary for either one of these. Even looking at grade 3 complete ruptures of the lateral ankle ligaments or the ligament of the medial aspect of the knee, because these get such great blood supply, the outcomes, whether grade 3s are treated through surgical intervention or through functional rehabilitation, have been very consistent to each other. So therefore, oftentimes surgical intervention is not recommended just due to the potential negative effects that can be associated with a surgical procedure. And then lastly, prophylactic bracing, while not completely solidified in the research, has been shown to potentially reduce risk of injury or re-injury to both lateral ankle sprains and to MCL sprains as well. So really, the only difference that you can see here and you see through research is the difference between time lost from sport. Lateral ankle sprains, you're looking at 3 to 7 days, whereas a MCL sprain, people are sitting out for up to 4 weeks. So my big question was why? Where's the difference coming from? And I think that can be explained one of two ways. One, I think athletic trainers understand the literature on lateral ankle sprains, but athletic trainers don't necessarily understand the literature of MCL sprains. Yes, grade 3 MCL sprains almost always have an associated injury to the ACL with them, but grade 1 MCL sprains, where there's not a lot of loss of function of the MCL, can be rehabbed quickly, and there was some evidence that shows that grade 1 ACL sprains or MCL sprains can actually come back within 10 days. So in conclusion, both MCL and lateral ankle sprains share similar anatomy and function. Both are treated relatively the same and support that treatment through research. And so I think moving forward, athletic trainers need to understand that both utilizing prophylactic bracing for early return and increasing their functional rehabilitation can reduce the amount of time lost from grade 1 MCL sprains if we start to treat them similar to lateral ankle sprains. And I think that that is supported through the findings in the literature, which you can see here. Thank you for listening. I hope that this was a productive discussion, and I look forward to bringing some new information as we continue through this DAT program. Thank you and have a great day.